It's a Northwest Lifestyle Weekend on Como News. IRG's Health Talk continues.
Our first guest, Dr. Michael Kim Orden, an orthopedic surgeon with advanced fellowship training in hip and knee replacements, talking about total joint replacement of the knee, something I just had a revision on. And Shannon, more and more technology involved here. They get you up and going right away.
More technology, better outcomes. I mean, we talked about prehab as a new rehab. What we've learned and what we're doing, patients, and the recovery time is accelerated for the most part. You still have to have biological healing. That has to take place, but much better opportunity to get back to function, right?
Absolutely. Dr. Michael Kim Orden and Shannon O'Kelly.
Dr. Kim Orden, welcome. How are you?
I'm good. How are you?
I'm doing great. Welcome to Health Talk. We're going to talk a little bit about health stuff, and today we're going to talk about orthopedic surgery, and particularly we're going to talk about total hips and total knees. But before we get to that, I always like to kind of learn who our guests are. We were talking offline. You have kind of an interesting past, I mean, from a standpoint of activities. Tell us about yourself. Tell us about how you got started in orthopedic surgery, your interest, and more importantly, kind of your training in this total joint fellowship program. Give us the day in the life, I always like to call it.
Yeah, so I grew up outside of Boston, Massachusetts, and went to Boston University, so I stuck around the area for a while. Was pretty involved in the whole Boston scene. I actually was a juggler growing up in Faneuil Hall Marketplace, and was pretty much infatuated by the city and had a great time. And my other big passion growing up was tennis, and went on to play at Boston University. And that sort of background, being hands-on, being active, led me to medicine and orthopedics in general. It's just, being on my feet all day and working and using my hands and creating something is sort of a natural progression for me.
Yeah, it's interesting that a lot of people that go into orthopedics sometimes are athletic or they had an injury. Did you ever have an injury that kind of spurred interest in that?
I did have an injury. That wasn't really the reason I went into it, but that was more just I like being active with my day. I like a good day's work, and that was really what it came down to.
And tell us why total joints, why replacing hips and knees, and maybe a little bit about your fellowship, where you trained at, because you have an interesting training background.
Yeah, I trained. I did my residency at Harbor UCLA in Los Angeles, which is a major trauma center. They treat all the high-speed accidents that occur on the major highways down there. I just found, to me, fixing broken bones and kind of fixing big arthritic joints and putting in lots of hardware was very satisfying to me. It's a very kind of before and after picture, and oftentimes, it can take. So there's definitely some recovery, and we'll talk about that with physical therapy, but there's also a very satisfying result sort of right afterwards often. And, that's what sort of led me into that.
Well, I mean, replacing an arthritic joint, I mean, we all know that as soon as you do that, I mean, people are very pleased. I mean, that nagging pain, that achiness, that discomfort, and lack of quality of life goes away. You change lives by replacing a hip and a knee. I mean, that's really something.
Yeah, and actually to that point, one of the things I take very seriously is I think you're correct. People do have a very immediate benefit and result, but I think you have to be very cautious with your indications and making sure that the right patients are getting it so that they realize those benefits.
Can we talk about those indications? I mean, you mentioned that, but I mean, that tells me you're going to try conservative care before you get into replacing the joint, whether it's the hip or knee.
Definitely. I mean, I really think, a real good effort should be undertaken with conservative care. That involves physical therapy, weight loss, modification of your activities, maybe cutting down on the high impact activities and increasing your low impact activities. Some pain medication, whether oral or pain shots into the joint. Because it's nice to know that both as the surgeon and the patient, when you get to that day and it's a big deal, you get to the operating room, you're confident you've tried everything else and that this is really the best course of action to go forward.
Is there an area that you specialize within that total joint, field?
Not necessarily. I do anterior and posterior hip replacements. I do total knee replacements, and then the large part of my fellowship training was, complex revision and being able to handle those challenging cases for folks that may have had complication from their first surgery, or maybe they just had it a long time ago and it's worn down and needs some parts exchanged. So that was a big part of my fellowship training. And I was at a major center and saw some of the most interesting cases, and gave me the confidence to go out and do it on my own.
More with Dr. Michael Kim Orden and Shannon O'Kelly next after this timeout on Como.
It's a Northwest Lifestyle Weekend on Como News. Now back to IRG's Health Talk.
Dr. Michael Kim Orden and Shannon O'Kelly talking about knee replacements here on Como.
Dr. Kim Orden, thank you again for joining us on Health Talk. Thank you for sharing your background, your interest, your training. I'm always fascinated how much time and skill you folks have, particularly when you start replacing someone's hip or knee. I do want to talk about the knee joint today. It's my favorite joint, by the way.
All right.
And it is complex. It has a hinge joint. It has a little bit of rotation. Listeners, if you have a arthritic knee and you're trying to get up and down stairs, move from a sit to stand, run, jump, twist, turn, whatever, it can be a real problem. You can change someone's life with this.
Yeah, so total knee replacement, as we talked about a little while ago, it's generally indicated. I like to say if you failed about 6 months of a good effort at conservative treatment, and then basically the procedure is you open up the knee joint, you take off the damaged cartilage that's become arthritic, and you replace that with a combination of metal and plastic. And that metal is integrated into the bone and fixed with cement. There are times when you actually don't use cement and can use a cementless prosthesis, but it's not quite as common. And then, folks, as you mentioned before, can realize the benefit of not having arthritis in their joint almost immediately. And of course, they have the pain from surgery, and that goes away with time. But, those folks can be up and walking the same day as surgery. It's done often now as an outpatient procedure where patients can go home the same day. And even if they need a night stay in the hospital, they still are expected to be up and walking and using their legs and using their new joint right away.
Yeah, so what we're talking about here is on a total knee replacement. You're replacing the end of the femur and you're putting and the end of the tibia. Yep. And then behind the kneecap, you put kind of a button on back there. So they have a totally new articular surfaces.
That's correct, yeah, of all three compartments of the knee. And there are some reasons why the patella may or may not get resurfaced.
Right. How do you decide to do the cemented version versus the bony in graft?
Well, I will tell you that in my residency, we trained doing a cementless prosthesis on a lot of patients. I'd say the more common procedure is to do a cement, and that's really historically the standard. For a younger patient who wants to have biologic ingrowth of their implants into the bone, a cementless prosthesis is an option. But there are some pitfalls that you have to be aware of with that procedure, and I take, if I were to elect to do that, I would make sure that I'm very careful who I select to do that, and they'll be set up for a good outcome.
Speaking of outcomes, I mean, you have your surgery. In just kind of in a nutshell, I know a lot of things can happen, but would you say 4 to 6 months after your surgery with a total knee, people are back to pretty normal activity?
Oh yeah, definitely by 4 to 6 months. There are definitely patients who realize that benefit earlier. Some folks take a little bit more time, I like to say patients are very happy to see me again around the 3-month mark. Even by 3 to 6 weeks, you should be back to all your activities of daily living in a relatively comfortable manner.
No, I mean, after 3 weeks, 2 to 3 weeks, I mean, people are really happy. They're happy the next day.
Yeah.
Is that achiness, that pain goes away. But as they return to function, this doesn't hurt, and they can get back to walking in some normalcy, right? That's what they really want.
Yeah.
You've been here since November. I want to say welcome to Northwest. Hey, will you come back on? I'd like to talk to you about these complex hip revisions. You're a total joint trained orthopedic surgeon. Can you come back on with me?
Definitely.
Thank you for your time.
Thank you.
You've been listening to Dr. Michael Kim Orden, orthopedic surgeon, talking about total joint replacement in general. Orthopedic specialist of Seattle.com. Shannon, we talked about this, the fact that I just had the knee revision, the fact that I'm up walking about 3 hours after the surgery. The amazing technology and advancements continue to astound me.
Well, it's fascinating how fast and how far the advancements have occurred over the last, I've been doing this for 32 years, and it's just amazing. Patients getting back to activity.
Okay, our next guest, Dr. Ron Kruger, next, right here on Como.